want to start with a disclaimer and then an apology. The disclaimer: I'm neither a GP nor a menopause specialist. I'm an emergency physician with more than a passing interest in trauma, which is quite strange. So that's my disclaimer. So when we get to any questions later, the clinical experts around the room, I'll be quickly giving them the hospital pass, being really sure about that. The apology is to the probably thousands of women that I looked after when I was an emergency physician, who I referred to rheumatologists for their intractable joint pain, who I started on gabapentin because I didn't know what else to do, to the cardiology clinics for the 24-hour tapes and the cardiac memos that I ordered because I couldn't work out what the tachycardia was. And that, can I tell you about last menstrual period? The only time I ever asked that was because I was interested in really an ectopic pregnancy. So menopausal hormones never got a look in for me. It wasn't part of my conscious thinking as an emergency physician. And to the thousands of women from the Northeast to the Midlands to Manchester, I apologise because I failed to understand the role that hormones really did play. And I think, I've been here 6 or 7 months. It would change what I did in an emergency department now. So, to all you guys who do it regularly, thank you for educating me. So this afternoon, we've got just over an hour to talk about testosterone. Question and answer session at the end. I'll meander when we're doing the question and answer session to distance myself from the experts. I don't want any questions. But first up is Catherine Coward. Catherine Coward is a GP, menopause specialist and senior clinician at Newson Health. Catherine was the lead for our testosterone quick start appointments. And somewhere over there, our team Coward, Hannah, Alice and Andrew. Where are you guys? Oh, you see, they're all a bit shy now. Alice, I think this is the second time you've heard me speak. I hope I'm better this time than I was last time. But without further ado, Catherine Coward, come and tell us about your case. Thank you.
Well, thank you so much. I'd got my patient ready to come and we're going to have a video link, but maybe she's just too busy and enjoying life now. We've got her sorted. It didn't quite work. So I have anonymised her name, but the case is hers. So I saw her, she consulted me here at Newson Health last summer. We'll call her Laura. She was 49. And the story was that her last period was when she was 42. She'd briefly taken HRT and then came back to the UK, consulted her general practitioner, who, and I'm sure I've been that general practitioner today as well, so this is no criticism. I am a general practitioner and it is a hard job, isn't it, to know everything about everything. And she was told she was a bit too young to be taking HRT and actually it was unsafe. So guess what? She agreed to stop it. So by the time I saw her last summer, she's a partner in London in a law firm, high pressure, and she just said, look, I'm really struggling with this. And if you look at my clinic notes, I don't recognise myself, there's no energy, no fun. Then she went on and I noticed in her MSQ score palpitations. I said, oh, tell me a bit more about that. She said, well, I've got used to those now, I've had them for so long, and I've seen a cardiologist, all is well. So I thought, that's great, yeah. But then, again, further on direct questioning, low-grade flushing, low-grade anxiety, she felt tense, low libido. Show me a 50-year-old lady with normal libido. I haven't seen one as yet. And I have got 2 daughters in the room, so that's as far as I'll go. And tired and poor sleep. Again, and I'm not apologising for this, a lot of what I'm going to be say today actually links in so well with all the speakers from this morning, so that's lovely. She also had vaginal irritation, and I find, unless you ask ladies about that, even in general practice, there aren't many women that will, particularly at 49, that will volunteer that information. And again, over-the-counter thrush treatments, a lot of women just go and buy that, and unless you ask about it, they don't volunteer it. She'd got all her lifestyle factors in place, she'd got no significant past medical history, and was on no medication. So in many ways, all very easy. Great. So we had our little chat and we talked about the safety of body identical HRT, and she went away with a prescription with estrogel I started on 2 pumps and just gave her the flexibility, using the Balance app to monitor her symptoms, after 2 to 4 weeks to increase to 3 or even 4 pumps. And we'll talk about the high-dose estrogen, as Louis said earlier, because it's so important that it's her symptoms, her dose, not my symptoms or my dose, is it? And she was given Utrogestan because she hadn't had a period for a few years. But more importantly, because yes, I am here to talk about testosterone and it is licensed for libido, but as a woman of that age, I find it really quite hard that testosterone and libido seem to be the two buzzwords, because libido is about a lot more than just testosterone, although I am the advocate for testosterone here. It's about how you feel, isn't it? It's about how you sleep. It's about how you exercise. It's a much broader piece, isn't it? Libido. And if your vagina's a crisp packet, well, say no more. So it's so important that we ask these questions, because for some ladies, just sorting out vaginal health can be really transformational. So we started some local vaginal estrogen. I will get to testosterone in a minute. So reviewed her 3 months or so later, calmer, clarity, palpitations gone, flush is gone, wow. Vagina more comfortable. No thrush treatment, no urinary tract infections since starting that little dose of estrogen. Libido still poor, but she said, I'm missing something. I've not got that drive. I've not got that energy that my job and my life need. So the shared management plan was that we would continue. I think she got up to 3 or possibly 4 pumps of gel alongside the estrogen and the Utrogestan. But we talked testosterone, and I'm now here. I've only got half an hour and I've only just arrived at where I wanted to be. So we talked about the different ways of giving testosterone, which I'll come on to in a minute, and we'll cover more in the practical sessions. So I'm going to sort of skate over that and come back to it at the end. But yes, she started 5 milligrams of testosterone every day as a cream on the outside of her thigh. I wished this is just normal in my clinical practice now, because I have given up general practice and I am purely a menopause specialist here. Welcome to my day. Game changer. I feel sharp, clarity, drive, focus. She just back to her normal self and life could continue. Libido had definitely improved. But she also mentioned, she said, oh, I didn't tell you about this, doc, but I had all these gut motility issues. They've all gone, and that's most likely the impact of the estrogen, although it doesn't often happen as quickly as the flush is going, but having been on it for nearly 6 months, that didn't surprise me either. And she also talked, it links into Louise's slide right at the start, about the immunology that we don't really understand, but she said she used to get these recurrent viral infections. Again, she was delighted because they had all gone too, but she got her ability to enjoy life, exercise, sleep, and dare I say the word with my daughters in the room, sex again. Though they wouldn't be here, would they, without sex? So maybe that's okay. So this is my talk. So that was introducing my lady. So testosterone in women, because I graduated in 1991, and until about 5 years ago, I did not know that I owned testosterone, that my body had testosterone. And I felt a little bit odd about that, but I did actually hear Dr. Louise say that she didn't know that until a few years ago, so I felt I was on a fairly good platform, so I have confessed that, but Louise, I do know a lot more about it now, hence why I'm here. So this is my talk. So I've got my 2 in 20 objectives. So we've got 2 objectives today, and I've been given 20 minutes to do that. Oh, I've got 19, that's good. So we want to rediscover that third female hormone, because for most of the audience here, I think we're quite comfortable and familiar using estrogen and progesterone. And yes, it's to restore libido, but I would say it's not just libido, it's fun and function. And hopefully by the end of the hour's session, to give people who want to give testosterone a go in their clinical practice the skills and confidence to do it, because once you do it, you then it's a game changer, and it changes your clinical practice. So why am I here? Why are you here? Why are you listening to me? Why does it need testosterone? Yes, we've had Magnus. Somebody said, why is Magnus facilitating a session on testosterone? So I just said to Claire, it's because he's a bloke. And there are a few men in the room, and I think, you know, we all know men have testosterone, but NICE 2015 say it's okay to give it for low sexual desire on top of HRT. But how does it happen that we then don't have a licensed product? That was 2015, guys. This is not right, is it? That we have a guidance saying we can, but then we don't have a product to do it with. I said earlier, libido, it's not just about testosterone, is it? It's about our libido is wrapped up with so many other things. So it's not okay to ignore testosterone. And as I said, I was completely unaware of this. And I'm sure there'll be other people in the room today who are unaware that as a woman, we do have testosterone. About 1/10 of the level of men. So guess what? The dose is 1/10 of the male dose. So it's not that hard, is it? And this common misconception that testosterone is only for men is so, so wrong. And if we castrate a man, sorry to use that horrible word, but we do, they come out with testosterone from hospital that day. I go through the menopause. I am castrated naturally. Question, is that the right word? And no, I am not allowed to have my own hormones back. So let's do a bit of a Dr. Google, because Google's really helpful, isn't it? It's really great when you're a doc. It's great doing virtual work, because you can have a quick Google if you need it. But if you Dr. Google it, you're not going to find female deficiency, unless you go onto our website, of course you will. But reduced sex drive, not a surprise. Reduced erectile function, less beard, so if that's a problem. Loss of lean muscle mass, feeling tired, weight gain, depression. Why is it any different in women than it is in men? It is not, and in clinical practice, it is not. So this is a slide. This is the second time you've seen it, and possibly the third. I do give this slide credit to Dan over there in the corner, who is taking over from me in a minute. Rebecca used it earlier. This is my visual representation. We'll go and have a little tour of the brain. And I am going to look at my notes at this point because my neurophysiology is not good. But let's go round the brain, shall we? So this, the little red dots are estradiol receptors, and the yellow ones are your testosterone. So there's your thalamus. And for those of you, and I am going to read from my notes, forgive me, the thalamus filters information between the brain and body. So that's connecting the two. Quite a helpful piece of the brain. Look, we've got estrogen and we've got testosterone receptors there, haven't we? Then we've got the hypothalamus, which is your temperature and appetite control. What a surprise, we've got estrogen and we've got testosterone receptors in that bit of the brain. Hippocampus, forgot that one. That was about 30 years ago, but believe it. Hippocampus is learning and memory. The amygdala, emotion. Striatum, initiation of movement and motivation. Then we've got, I don't know what came up there. Thalamus, no, we've done that one. Frontal cortex, decision-making, personality. Now, there are 3 members of my family and 2 ex-colleagues at the back. And I think if you talk to any of my family, I am a different person. I would not be standing on this stage today without testosterone. It is the hormone that, for me, transformed my personality. The people, these guys only know me, but the guys at the back do remember the mum, the wife of old. And I think if I were to stop my testosterone, I think they'd go on a family rota, although the kids have all left home, to slap it onto mother while she's asleep, because I think I am a better person using it. So, so that slide just confirms to us how, if there's a receptor there, I figure it wants something to bind, doesn't it? So testosterone, it's safe through the skin, not orally. Orally cause clots. We're talking transdermal. There is no breast cancer or clot risk. I think it was said earlier that for some lady with breast cancer, testosterone can be considered as an option. Let's look at the side effects, because we've got to give our ladies choices, haven't we? Yes, there will be a little bit of increased hair growth around the site of application, but you can epilate it or shave it off. Acne, and that tends to be the women who've got a long traumatic history of poor skin. And in those ladies, it wouldn't be a reason to not start it. I would just start it at lower dose and counsel and warn them. And if you stop it, it is reversible. The male pattern hair loss, very uncommon, and it's very hard to work out. Estrogen's really good for hair. It's very hard to work out, would this have happened? Is it the testosterone? But there are some, I saw a lady this week who clearly, it had happened when we introduced testosterone, we stopped it and it had reversed. So I think that is something we have to warn women about. But again, reversible. Nobody's ever told me about an enlarged clitoris, but apparently that is a case. But yeah. It works. I think our case from earlier demonstrates that. I am here today and I demonstrate it. Maybe I should skip on the first one, but whatever. These are the words ladies frequently tell us in the clinic, isn't it? And all my colleagues around here will say that. My libido is better. I'm no longer, it's that disconnect between life. I can remember names again. I've got my mojo back. I'm laughing again. My energy is back. I remember Christmas before I went on testosterone, and got a lovely family. We're all at home, the whole extended family, and it was a happy time. I knew it was a happy time. I knew it was a happy time. Things were good. My life was good, but I couldn't feel it. Christmas is since I am now, and this is the woman I am today, thanks to the opportunities here at Newson Health, but this is me. I am back, I am reconnected, and hopefully now back in the workforce, giving back to people just what I have been able to have. It restores. Dan is going to, thanks to Dan for the slide, but he's also going to do the clever bit, and he's going to present the data that we finally have got, that we know was there, but Dan and Aini have worked so hard. Thank you so much for getting the data for us. But yes, libido is multifactorial, but don't forget the vagina, and we now call it genitourinary syndrome of the menopause, genitourinary. So how does it look? I know I have the privilege to be a menopause specialist today, and so I have the options of private testosterone in the form of androfen, which we'll talk about in a minute, but even as when I was a general practitioner, and my colleagues on that table behind, I've left two back at the practice that I left. They still carry on to using testosterone. So well done, Team KNS. And my husband, who's a 60-year-old locum GP locally, will happily give testosterone out as well. So it can be done in general practice. It really can. It's probably the easiest of the three hormones. Androfen is the product that is licensed for women in Australia. It contains almond oil, so that needs remembering if you use that. We start them all at 5 milligrams. We can look at the actual practical prescribing in a minute. We've got the products here. Testosterone and Testim, although Testim is currently out of stock. So at the moment, if you are going to give it a go, I'd strongly suggest Testosterone. There are Testosterone pumps and Trostan at the bottom. For some areas, if you're stuck with your prescribing guidance, I'm aware that for some GPs, that's all they can. So we could talk about that in the practical sessions, because if that's all you've got, I'd prefer to work with what we've got than say a blanket no. And yes, I was tasked with rolling out what we call our testosterone quick start service, whereby we see women for a slightly cheaper appointment, for a short appointment, but for women who have been established very successfully on estrogen and or progesterone by their general practitioners, and they just want this because their general practitioner often is unable to issue it for different reasons. So yeah, well, the actual prescribing is very easy. Any of the products we rub into the outer thigh. Last week, again, I'm getting all these first. Now I work at Newson Health and I'm on testosterone. I did some filming, and we will soon have clips on our website showing you not just how to apply androfen, but also Testogel and Testim, because although it's very easy, trying to get the quantities right and using the different ones, it's really great in general practice. You say, just go to that website, because you just don't have that time, do you, in a 10, 15-minute appointment. So we will have all those resources for you to support prescribing. And if you've got any questions, I'm catherine.howard@newsonhealth.co.uk. I'd be happy to pick up the phone and talk to you to support you through, because, yeah, we are using off-licensed product, although regulated. Blood tests, we do advise them here at Newson Health. We do not advise that, we do not mandate that we do them before starting testosterone, because basically the symptoms say whether or not, and the age and the whole hormonal history will tell you if this lady is could do with testosterone. However, I certainly in general practice, I did a lot more bloods as baseline just because I was aware that I was working within a general practice setting. So again, you've just got to do what you feel comfortable with. But I would also, not always, but generally, if you've got a lady with PCOS, worth doing a baseline because they often have got a higher baseline of testosterone. And if you know what your baseline is, you know what you're working towards. But essentially symptoms. The problem with testosterone, it can take 3 to 6 months for full clinical impact. Some come back at 3 months, say, this is looking great. And I think often then up to 6 months, they get further benefit and possibly beyond that. If at 3 months they come in and say, look, no good, you do their bloods, they're low, and it's usually just a case of they need a higher dose because, as Louise is going to cover later, you know, our absorption through skin, it's getting drugs through skin is a bit of a tricky business. So, yeah, so what bloods do we do? Again, this is where it depends what access you have in general practice. There are some people that say you just look at total testosterone. Others look at free androgen index. We tend to look at free androgen index here, which is the best marker we have of the available testosterone to that woman's receptors in their brain that we looked at afterwards. 3 months there or thereabouts after starting, once that lady's got used to how much they're actually putting on, because it is, if anyone's used it, it can take a few weeks to get that right. We aim to get their free androgen index between about 2 and 5. Some people come back with a free androgen index at 1.5 and they feel fantastic, great, crack on. Others do need to run it higher, and the PCOS ladies often come in with a free androgen index that's a 2, so you're probably going to need to get that higher. Yeah, how to apply, as I said, the videos will be coming out within the next 2 or 3 weeks, and they will be freely available on our website. On our website and on the Balance app, there's loads of information to support women. So you can just say, go and look at the Balance app. Certainly that's what I encourage my husband to do. You know, because in general practice, you haven't got the time that we have here. We have all the information sheets on our website and the app. Oh, there you go. So that's, as I say, it is an important hormone. It is like estrogen. We have receptors everywhere. We have receptors also in our bones. We have them in our vagina. So yeah, it's a big topic, and we're going to do our practical prescribing and the questions that will hopefully enable us to pull this together for anyone who actually wants to say, well, how does it look? And I've got all my top tips in my little bag. So thank you for listening. Thank you.
Thank you, Catherine Coward. Thank you for rendering me hysterically blind. The crisp packet comment, dear God. Didn't know which particular rabbit hole we were going down there. And thank you, because there was one stage where you said, this is me, about 3 times, and I thought we were going into a Greatest Showman number. And it was going to be Testosterone the musical. But next up, in our afternoon of testosterone, can I introduce 2 people? So Aini Kamal, who's going to be on stage with Dan Reisel. Aini's a clinical research fellow at Newson Health and one of our data scientists. And Aini's one of those quiet people that does all the work actually behind the scenes. The heavy lifting is Aini. Sorry, Dan. And Dan Reisel's one of those people. He's our clinical head of research at Newson Health. And you talk to some people, specifically at Newson Health, tell me about your career, and you just think, you've done what? And then you did what? So Dan's got a neuroscience degree, a neuroscience PhD. He's a gynecologist. And he spent the last 10 years in academia. And all I've got to say is when him and Louise get going, I just sort of step back and leave them to it. I'm not getting involved. But welcome, guys.
Thank you, Magnus, for that suspiciously terse introduction. We've got about 20 minutes to talk with you about our data, which is exciting because it's actually the first time we share this. But we have some preliminary remarks, some introductory comments that we wanted to share as well, because this is really a huge privilege to be able to stand here and share this with you, all of you who are every day seeing women with the symptoms that we're very keen to address. I also want to acknowledge a few people who are patients and advocates in the room, and also to acknowledge Kate Muir, who is here, the producer of the myth, sex, and menopause, which has been part of this revolution that we're currently witnessing in menopause care. And I used the word revolution advisedly because actually a lot of this is political. Actually, a lot of this is not limited to our ken of clinical care, but actually spills over into a bigger societal conversation. So, so the one place to start in our societal conversation is Wikipedia, because Wikipedia often mirrors the kinds of discourse that goes on in the sciences and beyond. And you can see there that Wikipedia, for example, classifies testosterone as a male hormone. And you kind of would have thought that the second line should be, and it also has an important active role in women. In fact, if you look for women in the Wikipedia article, you have to search quite far. You have to pass a whole section of rodent words. And it's all about studies in rats and the testosterone-deprived mice and their copulation preferences and their sexual arousal. And having worked with mice in the lab for 5 years, I know that we try to stay away from female experimental animals because they were too complex. And so when you get to page 15, there's a small paragraph about women, and it's mainly about cuddling or post-cuddling. So I think, I mean, Wikipedia is not science, but I think it does point to a larger problem that we have around how we talk about testosterone in our clinical practice and in our science. And you know, it's 20 years, it's 100 years now since the suffragette movement, but the movement, you know, we're not done yet. There's still a battle that's going on, and we're all, you're all soldiers in that battle to a large extent. So symptoms that affect women in the menopause, needless to tell you, but it's worth pointing out that sexual dysfunction is only a little corner of all the things that we know affect women in the middle of their adult life, and that we know that hormones, including testosterone, have a big role in addressing. It is interesting to me that the only aspect of female physiology that women are allowed to have testosterone for happens to be the only aspect of female physiology that impacts men. And actually the nice definition is not, as Catherine pointed out, is not actually sexual function, it is sexual desire. So what we're trying to correct in our current policies on testosterone is women's lack of desire for men. Now, that could be a more, I mean, it could be the man who's the problem, for example, or the cost of living crisis, or Brexit, or a number of things that impacts on one's desire to post-cuddle. And this is perhaps the right place to introduce Sigmund Freud. And again, I know there are psychiatrists in the room, so I'm going to be, what do they say? If you're skating on thin ice, then speed is your main advantage. So I'm just going to touch on Freud now, and then we're going to come back to him at the end with his suggestive cigar there. Because he's really the reason why we talk about libido. I don't know if you've sort of thought about this ever. We sort of used the term libido. I think Catherine complicated it a bit by saying it's not just libido in a very strict, narrow sense. And I want to sort of amplify that point and say, if you, again, go to the internet and ask, what is libido? Well, it comes from the Latin, desire, lust, so far so good. But it actually travels through psychoanalysis from the time of the suffragettes, really, the turn of the last century, where it had a particular meaning. And somehow we've sort of picked it up from psychoanalysis and plunked it into nice guidance without any critical review at all. Because we use the term really as synonymous with sexual desire, sexual dysfunction, but in psychoanalysis it actually meant something different. And I think our data proves it. So we're going to end up on sort of expanding the definition of libido at the end. But before we get there, in order to qualify for testosterone treatment, there are quite a few hoops that women have to squeeze themselves through. And I just want to share this with you because I think it's outrageous. This is the DSM-5, and I'm looking at you, psychiatrist, wherever you are. DSM-5 criteria for hypoactive sexual desire disorder. The name of it is enough to put you off sex for a lifetime. Now you have to score 3 out of 6 of these, and it is reduced interest in sexual activity, it is reduced thoughts and fantasies. I don't know who has time for this these days. Reduced initiation of sexual activity, or being unreceptive to the partner's attempts to initiate. Or it feels like we're back with the rodents. Reduced excitement and pleasure during sexual activity, and it has to be 75% to 100. So if you're 74% of the time, you don't qualify for this one. A reduced sexual interest and arousal in response to internal or external erotic cues. They can be written, verbal, visual, WhatsApp, I don't know, TikTok. Absent or reduced genital or non-genital sensation during sexual activity, which is quite a high bar, actually. Again, 74% doesn't qualify you. And by the way, the symptoms in criterion A have to have persisted for more than 6 months. And by the way, symptoms in criterion A has to cause clinically significant distress. And there'll be some person somewhere in the DSM committee who sort of says, well, okay, we're going to quantify this. It has to be significant distress. It's not up to the individual to decide. It has to be sort of objectively proven. And in D there, it says that, you know, if your partner beats you, it doesn't count. Partner violence, which is all right. But I mean, I think this is a scandal. I don't know what you think. If you compare it to the hoops that men have to jump through in order to get a treatment for hyposexual desire disorder, or say decreased sexual function, it's essentially just having a credit card and buying Viagra, which is abundantly available at a cheap cost in pharmacy near you. So, with that background, I wanted to just point out that if you actually look at the biochemical components here, to talk about a male hormone and a female hormone just is nonsensical. It's literally the difference between a carbonyl group and a hydroxyl group at the bottom there, which is the difference between testosterone or estradiol. You can see how it's all part of the same hormone family, obviously abundant in men and women. In fact, you will know this, I'm sure, from your basic science and medical degrees, but it's actually the X chromosome that bestows the androgen receptor gene on men and women. And so it is our mothers we have to thank for testosterone in the body. I'm going to hand over to Aini and then come back with the results.
Thanks, Dan. So, just want to share a little personal story. I'm in my mid-20s, and I have my girlfriends around me, and I'm more of the women's health champion. You know, I kind of slap them if they don't go for their cervical smear. But they say to me, Aini, you know, you study the menopause, you research hormones. Do we have testosterone? And I say, not only do we have testosterone, we actually have more than estrogen circulating around our body. And, you know, if we look at this graph here, we can see when it comes to puberty, there's not only a spike in estrogen, but there's also a spike in testosterone. During the reproductive years, it remains stable, fluctuates during the menstrual cycle, and then also falls during the menopause and perimenopause. So it just kind of goes back to what Dan was saying about almost redefining testosterone, not just a male hormone, but a hormone that affects all. Just like the pay gap, we have the testosterone gap. So one main conclusion we can take from this is that, yes, males do have way more testosterone than we have. But if we look a little more into detail, there's 2 more things I want you to just take away from this. There's no curse from this, but the fall in testosterone in women actually happens a lot earlier than it does in men. That's number one. Number two, studies show that at the age of 40, testosterone falls by 50% compared to at the age of 30, whereas males just have a little decline, just a little gradual decrease.
Yeah, so to jump back in, just before I think this is the final slide before the results of the research that we've done internally. Just wanted to do a little bit of a deep dive in terms of the building on what Catherine said about what testosterone does in various parts of the brain. I think it's just interesting to look at mechanism, because we can talk about the clinical impact, but it's powerful actually to see the changes that happen with adding testosterone to a standard HRT regimen. And this is just a cartoon to show that when you give testosterone, it binds to a membrane receptor, it translocates to the nucleus, and it actually induces a bunch of transcription factors. And part of that is creating new dendritic spines, so that's the excitatory connections that allows neurons and interneurons to speak to each other more effectively. It actually induces neurogenesis, so new neurons and new synapses, and often silent synapses that then become functional based on following or later neuronal activity. Epigenetic, so those are the diacritical marks that sit on top of DNA and impact the amount of gene product that is transcribed, and post-translational modifications through, for example, the Krebs cycle, and mediation of neurotransmitters, and particularly dopamine and the D2 neurotransmitter, which is a close cousin of testosterone in the brain. And you can see how that links in with testosterone really being having a massive impact on motivation and activation of behavioral schemas. Testosterone literally is food for thought, because it increases metabolism and sugar uptake of bits of the brain. It has a direct impact on both grey white matter and white matter, and that's why we see the cognitive effects that we see. So the cognitive effects that we see are powerful, and I'm going to let Aini, because again, to pay tribute to her and the rest of the research team, this is a work of about 6 months, and we're excited to share it with you.
So at Newson Health, we carried out a retrospective cohort study with patients at Newson Health. We selected patients who were established on HRT, so estrogen and progesterone, and we asked them to complete a menopause symptom questionnaire, or MSQ, also known as the Green Climacteric Scale. And after completing that, they were then prescribed testosterone by our lovely clinicians. And once they came back for their follow-up, which was a few months later, we then asked them to complete the MSQ once again. And the primary objective of this study was to compare the scores before and after testosterone was started. The Green Climacteric Scale is a validated questionnaire used to assess menopausal symptoms, and you can see there's about 21 there, and they span from concentration to headaches to anxiety, and patients are asked to scale it from 0 to 3, 0 being not at all, 1 being little, 2 being quite a bit, and 3 being extremely.
Thank you. So yeah, and to be honest, we were a bit shocked by this, because you would have expected maybe some improvement in certain domains. We didn't expect it to be a sort of across-the-board improvement of a magnitude of between 30 and 40%. And you can see here, apologies for the people in the back, the writing is on the small side, but just to read it out, the domains that are most closely linked to mood are feeling unhappy and depressed, 43% symptom improvement, feeling tense and nervous, 32% symptom improvement, loss of interest in most things, which I always thought was a bit of a weird category, because to sit there as a patient and say, I've lost interest in most things, is actually quite a high bar, a kind of a marker, I guess, of major depression. But you see a 44% symptom improvement, magnitude of symptom improvement, and attacks of anxiety and panic attacks, 42% symptom improvement. So just to explain the graph, On the y-axis, you have the score from the green climacteric. That's why all the blue bars are in between 2 and 3, because we selected women who were either moderately or severely affected. And then the orange bars are the 3 to 6 months after starting testosterone. Now, these are women who is sort of a consecutive series of women patients at Newson Health, almost 1,000. But of course, some of those women, because this was sort of observational study, we went back and looked at data that was collected at the time, but it wasn't a clinical trial. Some of those women who were in our study also had changes in estrogen at the time of starting testosterone. So one worry that we had was, well, could it be that this is actually all estrogen? And so we specifically looked at that, because we sort of wanted to break this data. How can we prove that what we found is not true, which is the right approach? And here you see the comparison between those women who had no change in estrogen, 405 women, and the women who had a small increase in their estrogen, 490. And so the two blue bars are the two pre-climacteric scores for each domain for those two groups, and the two orange bars are the ones after 3 to 6 months. And you can see there isn't any statistical relationship, no difference in whether you start if you increase estrogen at the time of testosterone initiation or if you don't. In fact, the trend goes the other way. So the light bars are the ones that had estrogen increased, and actually their symptom score is slightly less, although it's not significant. The trend is in that direction. So the clinical implication of that is when we start people on testosterone, it probably doesn't make any sense to increase estrogen, and maybe even we should think of testosterone as an estrogen-sparing hormone, and it might be able to roll back, maybe tail back slightly the amount of estrogen a person is on, because they have the same symptom improvement at a lower level of estrogen. So that was really reassuring for us, because it means that the effect really here is all driven by testosterone. And this is another way of looking at the same data. Again, we wanted to try to break the data and make it, see if it would hold up. And this is not the amount of symptom change, but the proportion of women in each domain who had any kind of symptom improvement. So they went from a 3 to a 2, or a 2 to a 1, or a 1 to a 0. And you can see it's just labeled in colors and different sort of groups of symptoms. So the blues are, I'll just read it out. The blues are loss of interest in most things and feeling unhappy, so that's sort of mood, depression. The reds are attacks of anxiety, panic attacks, irritability, and feeling tense and nervous. Those are the more anxiety-related ones. We're going to leave libido to last. And then the purples are difficulty concentrating and memory problems. Those are the more cognitive symptoms. And then sleep and energy there in the green. And as you can see, libido, which is the only symptom that testosterone is licensed for in the UK, as per NICE guidance, comes in as a distant fifth. And you can see the across the board effect here. And of course, if your sleep is improved and your energy is improved, your memory is improved, you might remember to have sex too. So the 3 take-home messages Aini is going to leave you with.
So number 1, restricting testosterone to those women who fulfill HSDD criteria would miss a large proportion of women who would have positive effects on cognition and mood. Cognitive and mood effects were seen across all domains, most pronounced on depression and anxiety, less so for memory and concentration. And lastly, it made no difference for symptom improvement to increase estrogen at the same time as initiating testosterone.
So then finally, in the last 10 seconds, to just revert to our friend Sigmund Freud. If you actually read the piece where he introduces the concept of libido, what does it mean to be libidinous? He says the following: libido is an expression taken from the theory of emotions. We call by that name the energy regarded as a quantitative magnitude, though not at presently actually measurable. I'm pleased to say we have now measured it, of those instincts which have to do with all that might be comprised under the word love. But we don't separate from this what in any case has a share in the name love. On the one hand, self-love, On the other, love for parents and children, and friendship and love for humanity in general, and also devotion to concrete objects and to abstract ideas. That is what Freud said about libido. And I think it actually maps on really well to what libido does in the brain, because it's not related to sexual desire at all, not limited to sexual desire. It's actually being joyful and connected to all of life. Thank you.
Thank you both, and on time too. Can I invite 2 more people to the stage? Can I introduce Hayley Berry? Hayley Berry is a senior clinician at Newson Health, pharmacist and educator. Andrew Melvin is one of our pharmacists who does, again, quite a lot of heavy lifting behind the scenes, quite a lot of the audit work that we need. Andrew manages to provide us with the details. And there's the ever-youthful, testosterone-fueled Catherine Coward at the end. So this is a testosterone question and answer session. The microphones are, oh God, the hands are going like crazy. We've got to go to Andrew Coward first. I want to hear what he's got to say. If it's about crisp packets, I'm closing it down.
You can answer that one.
Yeah, I really enjoyed both talks. If it's okay, Dan, to say one more than the other, but I have to declare a vested interest. So I'm a GP. My question is, I think to you, Dan, actually, when we start estrogen, it's for symptom control and disease prevention. And so far, obviously, the discussion about testosterone has been about symptom control. So my question is, can you speculate, or is there any evidence of testosterone in a similar way to estrogen having a role in disease prevention as well?
Well,
I think we can
over to you,
speculate, can't
Dr.
we?
Reisel.
Yeah, I think we can speculate, can't we? I think from a physiological point of view, from looking at the effects of testosterone on many tissues, but particularly the brain, I think it makes physiological sense. I don't think those studies haven't been done, but I think we should work towards carrying them out and making sure that they're and perhaps even starting testosterone earlier than estrogen, because it drops earlier in women, as Aini pointed out. The drop is much more marked than in men. It's much more of a cliff than a slope, and the risk profile is better. I mean, we think HRT is safe, but testosterone is even more safe.
Thank you. Who's next? I'll let. Thank you.
Just on that, in terms of safety, so we know that testosterone intraconverts to estradiol and vice versa. So I'm assuming in clinical practice that some of the testosterone that I'm giving is converting to estradiol. And so then you have to think about the risk profile of estradiol when you're supplementing. Does anyone else agree with that?
I'll do A&E questions. Quite happy to do that. You know, when you look at an audio and you look at the panel and you're thinking, crikey, I hope somebody says something meaningful.
I mean, we call it aromatization, and I think we've all used that as a reason for not initiating testosterone until we've got the estrogen up. I've been in that camp, absolutely, but I think in reality that aromatization is very low, very minimal, and we don't really see it in clinical practice. Call that a simple answer.
I also think
a more complex one.
Well, just to add that we rarely start testosterone without standard HRT, which and the progesterone component of standard HRT is very likely sufficient.
I'm guessing I'm thinking when you're saying it's safe in breast cancer, that's what's just I'm not saying that's wrong. I'm wondering what.
The only time I use
estrogen,
oh, sorry.
Yeah. Estrogen is not an independent risk factor for breast cancer.
No, I know.
So,
I know.
Yeah. It doesn't convert into progesterone, which is lucky.
Float. Thank you.
Hi, I'm Dr. Fiona Rennie. I'm a menopause specialist from Dubai. I've just had an issue with, I prescribe a lot of testosterone, a patient who is a weightlifter, and she's been banned from competitions. She takes physiological doses of testosterone. Now, my thinking is that actually wouldn't show in a drug test if it's physiological. If I'm keeping her FAI between 2 and 5, but she just cannot get past the international body. But male weightlifters taking physiological doses, okay. Have you had that experience? I wasn't quite sure what to do. I was inclined to say to her, just
Crack on.
yeah. Would it show up in a drug test?
Can I, I'm going to hand this to Louise because we've been having conversations with WADA about this very issue.
Switched on, am I? By magic, switched on.
Magic.
Look at that.
Hey.
Incredible. Yeah, it's really, really important, and you're absolutely right. I don't know that you would know any difference whether you do have a, endogenous or exogenous testosterone, but morally they can't do that, can they? So I've got quite a few patients who are extreme athletes, and they're now having to decide between their career or getting not just their sex drive back, but everything else, because they've got testosterone deficiency symptoms, low testosterone on a blood test, and they're optimally managed with estrogen. So we've been taking it to WADA, and there is now, because of gender inequality, I've used words like horrendous misogyny, inequality. They're sort of getting a bit okay about it, actually. So we've had some really good meetings, and the last few weeks even, there's been some really positive movements. We're sort of going to different smaller groups, so the cyclists, the triathlon groups in the UK, but they all feed in worldwide as well. And I think it's absolutely, when I say to them, isn't it morally wrong that a man could have an orchidectomy age 20 and be allowed with a medical exemption certificate to have testosterone, yet a woman age 20 could have a orchidectomy and, she couldn't have an orchidectomy, she could have a bilateral nephrectomy, and she can't. It's not even about the older women, this is about younger women as well. I think actually this is a real gender inequality issue. So they are actually really taking it seriously, and we're just doing a questionnaire now under the guise of Dan to asking more about this. So we've got some more sort of evidence about how it's really affecting people as well. It's not just us saying, and so they're using me as a medical expert. So it's really, really important, but it's quite encouraging for the group of women that it's affecting as well to know that there's some change happening. It's really important. So I hope that helps. I haven't given you an answer, but it's really, really important. It's on people's radars now, which has only taken 7 years to get to this step.
Thanks, Louise. More questions? Down at the front here. Go next with you. Fair enough.
Here. Thank you. I just found that fascinating and really good, and glad that research is being done. I just had a practical question. When the women were given testosterone, there's 905, were they all on androfen?
No.
No, so any testosterone?
Yeah.
Okay.
Test.
Brilliant. And you didn't allude to this, so it's irrelevant of the estrogen level before you start testosterone. It's purely on symptoms.
Yeah.
Yep.
We don't routinely do estrogen levels. I think that's one of the questions that's coming up later. But
Perfect.
In clinical practice, the only time I really do estrogen levels is questioning absorption. You've got someone who's not responding, or maybe the patch, they're not absorbing from patch. So no, I wouldn't do pre-treatment estrogen or testosterone.
There's a real resistance in a lot of areas of general practice to just to hold off testosterone because they can't check baseline levels of free androgen index because it's not available on the lab. So it's just really nice to be able to feed that back. Thank you.
Thank you.
I just wanted to make a small point in answer to the question from earlier about breast cancer, or, that's when you're worried about aromatization. So there's very limited data when it comes to testosterone and breast cancer, but in preclinical studies, so studies that have looked at breast cancer cell lines and animal models, testosterone has an anti-proliferative, pro-apoptotic effect, i.e. it has the opposite effects of estrogen on tumour growth. And having the androgen receptor is associated with a good prognosis. There was a good article in Nature in 2021 about that. And there's very limited data that women who take testosterone are at a lower risk of developing breast cancer in the future, just observational data. And then finally, there's some limited data. There's a surgeon in the States called Rebecca Glazer who's using combined aromatase inhibitor and testosterone pellets to treat breast cancer. Now, obviously, it's you can't tease out what's the AI effect and what's the testosterone effect, but anecdotally, her evidence suggests that her outcomes are much better in those patients than in women who use AIs alone. So it's very limited data, but what we do have is very reassuring, and I don't worry about giving testosterone. Final point, it's quite useful in women who are using AIs and want to stay on the AI for some reason. You can obviously use testosterone in those women because that you're preventing aromatization to estradiol anyway, if that's what they're really worried about.
Thanks, Sarah.
And testosterone actually helps, flushes, doesn't it? So you've got people on AIs, and we've always said they are rubbish drugs, aren't they, in terms of side effects. You put testosterone in, and it's amazing. I remember I had one lady full of symptoms, and Louise was actually in the building, and I panicked, said, yeah, let's do testosterone. And she had so many flushes. I went through to Louise, I said, look, what am I going to do about her flushes? And she said, your testosterone will work, Catherine. That's the first time I did it, and it absolutely did.
Yeah, I mean, in my experience, it is variable, but absolutely one of the case histories I presented earlier was the one that had only started testosterone and her hot flushes had decreased. But she still had anxiety, so it's very different, but it's definitely worth a try, yeah.
Thank you. Question here at the front.
Hello. I think my question probably is similar to the previous one, but it's just that I've got to try and get my head around this new thing about adding testosterone and it not making a difference, increasing the estrogen, because at the moment what I do is have a discussion and we start estrogen generally and progesterone, and then we kind of get the estrogen dose right, and then we add in testosterone, and I do check FAI because I'm in general practice, like Catherine said, and then we kind of go from there. But actually, should I be adding in testosterone and not increasing the estrogen? And it's not just about the mental health symptoms, is it? It's about, so when I don't quite know what to think now.
I think
Hayley,
I think it's really about seeing what the patient wants to do. I mean, I have that open discussion at that initial consultation, because some women don't need testosterone, do they? That some women, their symptoms improve with just their estrogen and progesterone alone. But actually, we know it takes 3 to 6 months to start working. We're impatient. I don't want to wait 6 months for my treatment to start working. So actually, if they start it at that initial consultation, when they come back to see you, you can always tell, and I don't know if you've noticed this, that people who've started testosterone at that initial consultation where they've started their HRT have had a huge improvement in their MSQ scores. I don't know if you'd all agree with that. So it's just having that conversation with them. I don't think there's a right or wrong. Obviously, nice guidance is they need to have tried standard HRT first, but actually if you've got someone in front of you that you know is going to benefit from testosterone, have that open discussion with them, because I think it really does make a difference when they come back for follow-up.
Thank you.
Thank you. Anything to add from any? No. Next question. 5 minutes left.
Thank you. I wanted to ask about monitoring, because we always do the 3-month check, and then a lot of the stuff I read is about an annual check. I don't know if that's your standard practice.
Perfect. And a clinical review. I wouldn't just do a blood test. Yeah, a face-to-face, ideally an FAI or total testosterone, whatever you've got. Brilliant.
And is that lifelong?
At the moment, that's what.
And any chance of it going on the prepay for HRT?
No. We haven't even got it yet to go on the payment.
When the MHRA eventually decide that we're going to have a product in 525 days, I think they've said. 552 days. So there is a licensing application in with the MHRA for Androfem. And the MHRA have a stipulation, a guideline for days it would take to respond. The normal response number of days is 150. They've said 552. So clearly not a priority for MHRA at the moment. And read into that what you will. But it's not going to be any time soon. Next question. One at the back. Thank you.
I found this absolutely fascinating, so thank you. Is there, well, you've talked about lots of advantages. What's stopping us put every woman on HRT and testosterone?
There we go.
Yeah.
Drop the mic. Had to happen. I'm surprised it took so long. Who wants to take that?
Because it's dangerous. You get people like me.
We'd run out of cerise suits nationally.
I think it's great. That's what we're here to do, isn't it?
Anyone?
I can't come up with a reason why not. Oh, Louise is coming up with one.
On again, sorry, thank you. I think it's a great question, and we battle a lot with NHS England, because the last meeting I went to, when I had my camera off and was muted like a teenager because I was getting upset,
Thank you. So I just want to finish with something for you all to ponder. So prior to being CMO at Newson Health, I was CMO in a large acute trust, and I was CMO through the whole of COVID. And during the first wave of COVID, we went from 2 intensive care units of about 40 beds to 2 intensive care units of 97 beds. So we got all the ventilators in from theatre. And I was chatting with Louise, and Louise said to me, just ask the guys in ITU, ask them what? And she said, how many patients have you got in intensive care who are on HRT? And I thought, strange question. Anyway, I ring up both ITU lead consultants and say, just go and do this work for me, find out. Not a single patient. Not a single woman was admitted to intensive care or to respiratory HDU with COVID who was on HRT. And it's anecdote, and it means, literally means nothing. But what else is in there? How many of those were on testosterone? I don't know, because I didn't ask that question. But the anti-inflammatory impact of the hormones mustn't be, I suppose, misunderstood. And there's loads of work to do there. And it's only now that my eyes are opened. So, yeah, another apology from the A&E consultant. But can I thank the panel? Thank you all. Thank you for your presentation. And it's time for tea. See you in 15 minutes for prescribing.